All right, so let's talk about acute ischemic
Acute stroke.
This is a moving target.
It's
Definitely. So common. We worry about it so much. We see a lot of patients that come in where we have to be thinking about this, right? 700,000 cases per year.
A lot of people.
Right? And in the last 3 decades, there's been a lot of literature that's been coming out, some of it conflicting.
And keeping up with it is almost,
it's insane.
It's so hard.
Yeah. We're going to try to summarize some of that for you, but
At least what this article says. Yes.
Exactly. But you got to kind of see what your institution's doing and having them update things, but we'll go through this. So treatment, as you know, is guided by time from onset of stroke symptoms to arrival to the ED, because that can be different depending on how time sensitive or how soon someone presents, right? And then severity of their neurodeficits is another sort of indicator of what might happen.
Yeah, what you may or may not do.
Right, exactly. And then findings on neuroimaging. So when that radiologist calls you with what they see on the CT scan or MR or whatever, then you can have a conversation and guided from that as well.
Right.
So onset is really important. So always asking, when was that last known well time? Did they go to bed with this symptom? Yeah. Did you see them beforehand? Is it a wake-up stroke or not? I mean, there's a lot of ramifications now based on the timing. So it's really important to suss out. Ask the paramedics, call for collateral. It's going to be really key in trying to figure out what treatment modalities
and
you
you're on
kind
the clock.
Pursue.
So you have,
time is brain, right? So severity, so up front, most people want to use an 8 stroke scale. That's a good way to objectively talk about your neurodeficits.
And a lot of things were studied based on that too.
Exactly, right. And needing that NIHSS is really important in how you communicate to your neurologist or your interventionalist or whoever it is, right? So got to make sure you get a blood glucose, right? This is like one of those things where it's the mimic and you can do something about it, right?
It's
so
like
get
magic.
The bedside glucose.
It's all better.
Oh, shocking. Your glucose is 20. Let me fix that for you. All right. So treat any hypoglycemia. And then if there is a concern for stroke, you got to get that patient to the knock on CT head as fast as possible.
Yep.
Don't delay it for the IV.
No.
Don't delay it for anything else except maybe the glucose and get them over. If they're clinically stable, you got to get that.
Finger stick in the scanner.
Exactly, right. And then if it's negative in the appropriate situation, you're still worried about acute ischemic stroke, right? Because it may not have been long enough for that to show up on the CT scan. And for MRR, so, there's all this sort of discussion nowadays based on the newer literature of trying to figure out how much penumbra is left, how much tissue is left to save that's ischemic but not dead, right? And so you can get that different ways. You can get it with a CT perfusion scan. You can also get it with a diffusion-weighted MR, and you're really trying to calculate what the mismatch is and then figuring out how big is that penumbra, because that'll have implications later.
Right, and we don't figure that out, right? These are the experts that are reading this stuff that just convey to us that there is a salvageable brain.
Absolutely,
part of a brain.
Right. And then if you're looking for large vessel occlusions, right, getting the A part of the CTA or the MRA is going to be really important.
Right, so we've really changed a lot of it. We've changed a lot of this, and a lot of is getting a lot of imaging pretty quickly.
Yes, right. And then your place will have different protocols, right? Like some people might be able to get the MR quickly. Some of us can't. And you just get the CTA or CT perfusion. Some of us, many of us. I don't know.
Yeah, exactly.
You fancy, you have an MR. But, so most of us aren't there yet. And so the treatment response, a lot of this is using the modified Rankin scale. So just for reference, if you have 0, you have no symptoms. Really anything less than 2, you're functionally independent. And that's what we're really trying to aim for.
Yeah.
And then, 6 is
walking, talking, being able to take care of yourself.
Right. 6 is bad. All right.
6 is dead.
Yeah, I know. It's kind of bad. So Alteplase, right? So right now, anything less than 4.5 hours, TPA is still considered first line. So the dose, just so as a refresher, it's 0.9 milligrams per kilo over 60 minutes, and then a max of 90 milligrams, and then 10% bolus over 1 minute, and then you give the infusion afterwards. So logistically, this is a little bit tricky, but it does reduce the disability from ischemic stroke. I mean, there were studies that have shown this. It is not recommended, however, in the minor strokes, right?
No.
The really, really mild
This
ones.
is actually really important. That study was a game changer.
Right. And so NIHSS of less than 6, you probably shouldn't be giving TPA to.
No, in fact, you should not. It is frankly not recommended.
Right. And then excessive bleeding risk, if you have somebody who has a bleeding risk, some sort of coagulopathy, before you even get into having a stroke, you don't want to give it to them. And then if the CT shows a irreversible brain injury, so this is something where it's a little bit more subtle, but like if you have somebody that has that, you want to have that conversation with the neurologist. Is it worth it?
Yeah.
Okay. So you can give it as soon as that non-CAR CT is negative, right? There's no bleed. We're starting the TPA because that time, tissue, brain thing, we want to get it on board as soon as possible. And you don't want to wait for the results of the labs, right? So you don't want to know what the platelet count is or the INR.
And this is, if you're practicing a while, these are changes from the original. I mean, the original, you had all these, like, well, you wait for this and you do this. And this is like, they've really pushed this right up front.
Right. They really want you to give it as soon as possible, not having to wait for these other things. Blood pressure is something we do need to manage, though, before we give the TPA. So you want to get that less than 185, 110, and you really want to keep it under 180, 105 for the first 24 hours afterwards as well.
And which we are doing in the ER because we're holding people for so long.
Yeah, don't get me started on boarding.
I
know. And then for ICU admissions, these patients need really strict monitoring. So they're going to go up to the ICU. And ideally, if you're at a place that has a stroke unit that specializes in this, you want that patient to go there.
I would want to be there.
I would want to be there too. I'd want my mom to be there, dad to be there, et cetera. Like that's just where the best care is. And the benefit is time dependent. So again, really moving that needle of giving it as soon as possible, right?
And this is actually where the people that are the naysayers, the window that it really works the best is up to 3 hours. Exactly. We added 3 to 4.5 for a little teeny bit of benefit. And some people even doubt that. But this is, so sooner the better if you're going to do this.
We could go into the articles and the controversy, but we're not going to here. We're going to spare you
from that. This is all you need to know for the exam that you're taking.
Yes, 3 hours, best benefit. 3 to 4.5, maybe still some benefit. Of course, we all know the adverse outcomes, right? You can get bleeds from this. In studies, it was shown that it'd be 6.8% of bleeds versus 1.3%.
It's a lot more. It's a lot more.
Yeah, right. And I think we've all seen that.
Yeah.
And there is increased morbidity mortality risk, but there's also some maybe increased benefits. So you kind of have to talk about those things with the patient, see what they're okay with.
You do. And that's a whole other controversial thing, but I'm still a big believer in talking to folks about whether they want this or not.
Yes. So in terms of that expanded window, we got to talk about the Wake Up study, right? And so this is really a study that talks about, well, if I went to bed and I was fine and I woke up with my stroke, how long has it been since I've been having stroke symptoms when the patient can't tell you, right? And so you are trying to get at a specific size lesion to be included in the study. And it's really getting to that penumbra thing that we talked about, right? How much of brain is salvageable? And is that benefit for TPA there versus am I just going to have more bleeding risk? And it's trying to really suss that out. They need NIH-SS scores of 25, less than 25. And to be included in the study, you were not to have a thrombectomy planned.
Right.
And the endpoint was, again, sort of this modified Rankin scale of how much functional disability did you have. And it was really trying to get them to 0-1, this really independent person at 90 days. And the treatment benefit you can see here is 53% versus 42% if you didn't get alteplase in that extended window. And so for patients, if there's no thrombectomy available, the conclusion was, well, maybe you can still give alteplase up to a certain number of hours. They said maybe 9 hours here if you met the criteria in the clinical trial.
Right. So it gets kind of complicated. This is one where your institution you're going to follow what you do at your institution. For this particular paper and for taking this test, they actually didn't get into a lot of detail as far as if it meets the criteria. They didn't really get into a lot of the details. So I think the key here is to real life know what you do in your own institution. For this exam, I think they'll keep the questions pretty simple. I don't think they'll get into all the little nuances.
I think it's also helpful just to know that this is existing literature that's coming out, that like if you're, people aren't, it's not crazy to say you could give it after 4.5 hours if you can identify of those patients.
The right people.
Exactly. Really identifying the right people, whether that's with MRI imaging, et cetera, to try to find that penumbra. Okay. Next one. So mechanical thrombectomy. So in less than 6 hours, right, that shows the biggest benefit. And the idea is that you're like getting the clot somehow. You're catching it, sucking it out, go fetch it, right? And then you can save the brain. This is best in large vessel occlusions, right? You can imagine like just how hard it would be to get in something teeny tiny, but really the large vessel occlusions is where you've seen the most benefit. So you do need some sort of imaging to figure out if it's a large vessel occlusion. Typically it's an A part, right? CTA or MRA. And then it's really the more severe strokes, and IHSS is of 6 or higher. And it's the most benefit within 6 hours. There's some studies to say it can go on past that, but that's really a conversation you got to have with your specialist at your shop.
And I'm sure if you have this at your place, you already have all your rules down on what they're doing.
Yes, exactly. So several studies showing that thrombectomy can be done, and most of these patients did get IV alteplase while they were sort of getting prepared for their thrombectomy. So just because you got TPA doesn't mean you're excluded from getting thrombectomy. Right. Some did, some didn't. The current recommendation is still to give it. So if you have alteplase and it's a person who qualifies for it, then you should still give it even while you're planning for the thrombectomy. Okay. So there were 2 trials that looked at this. One was a Dawn one, and this is when I was talking about like stroke symptoms 6 up to 24 hours here.
Yeah, this is now further
out, right? And now we're talking about NIHSs of 10 or higher, so more severe strokes. And there were specific imaging criteria, which I won't really get into, but that did show a benefit of thrombectomy in this other extended window, so up to 24 hours here.
Yeah, they also bumped their modified Rankin up to 2, but they kind of cheated a little bit. But yes, they found a benefit.
Yes, so they found a benefit here. So take that for what you will. The other study is called Diffuse. I love how they all happen to make up like these
people
acronyms.
Sit around and make these names up.
I'm sure they think about it for a long time.
I'm sure they do.
But again, it's another study talking about this expanded window of like 6 to 16 hours.
Yeah, not 24 like the Dawn was. It's only 16.
Right, yeah. And really trying to identify that mismatch of the core penumbra, like salvageable brain. And this one was NIH scores of 6 or greater. They found a benefit, 45% versus 17%, with again a modified Rankin score of 0 to 2.
Yeah, they kind of cheated a little.
Yeah, a little bit. But it's out there, so now you know.
Yeah.
And in terms of blood pressure management, specifically for patients getting thrombectomy, it's not really clear guidelines for blood pressure management as opposed to TPA. Like we have a very clear goal, but for thrombectomy patients, it's a little bit more up in the air. Yeah. So it's considered reasonable to maintain that blood pressure. I know. I'm like, what do I do with that? During procedure and for the first 24 hours. So I think most places still logistically end up doing the blood pressure management, even if you got the thrombectomy only. Because oftentimes these patients, like we talked about, some are getting TPA and thrombectomy. They're going to stroke units where they're really watching the blood pressure. And so this is out there. It's a little unclear, but, I guess.
And if anybody says they know for sure, they're not telling the truth.
Yeah, it's not clear.
No.
The other new sort of player on the lytic options out there is Tenecteplase. We don't have it at our place, and I'm really curious to see where this goes because it is much easier to give a single IV bolus of Tenecteplase or TNK than it is to give TPA in that like infusion bolus situation. And so the idea is that if you can get the bolus in, you're saving more tissue instead of having to have this do more complicated bolus infusion thing with TPA.
Which potential error as well.
Exactly, right. And it's just more time to get it set up. And the idea here is that it's another sort of tissue plasminogen activator, and it's more fibrin specific, and it's resistant to the plasminogen activator inhibitor, and it has a longer half-life. So all to say that there are studies that are now showing that it's pretty equivalent.
Yeah, it's working its way into the market that already was studied under Alteplase forever.
Yeah. So there's been a few studies, 5 randomized trials comparing it to standard doses of Alteplase, right? That 0.9 that we talked about milligrams per kilo. And then it showed that in these meta-analyses that there really was no significant difference between getting TNK versus TPA. And they looked at the modified Rankin score of 0 to 1 being functionally independent at the 90-day mark. So it's hard to say because I think that we're still at this early period of trying to figure out.
It's worked its way into the guideline as an alternative. So
Correct.
It's out there.
Right.
And it's in this article as something to be aware of. But it's definitely it's now into the guideline.
Right. And so, again, what else can we do for these strokes? Like, it's hard.
Back in the day, this is all we did.
Right, exactly. And so this conversation here is talking about anti-thrombotic agents and the role for these, right? Anti-platelet agents usually delayed for 24 hours after IV TPA because you just don't want to have to make them bleed more and then more. Just one thing at a time.
Yeah.
And they're here specifically for aspirin. 160 to 300 milligrams does lower the risk of recurrent stroke of death in the hospital later compared to placebo. So, and then for those patients who have an NIHSS of 3 or less,
we're getting down to
little,
like really
minor,
little tiny.
Yeah, really. Yeah, there's really not an indication here for long-term anticoagulation, right? They say,
and these also are people you're not going to be lysing, right? They're under that cutoff.
Right, exactly. So dual antiplatelet therapy within 24 hours of stroke onset may be better than aspirin alone. They say that there's decreased risk of subsequent stroke as well. You can start regimen of aspirin and Plavix, or you can just do Plavix as well. Yeah, I think this is a conversation you have with the neurologist.
The good news for us is that you don't have to start it till later. Right. In fact, you don't start it till later.
No, this is a conversation. This is what people do after you've figured out what's going on. This is beyond us. Okay. So therapeutic anticoagulation, right, within 48 hours is not better than aspirin alone or placebo. Here, if you're doing heparin drips or things like that, it's really not necessary. You're just increasing the risk of bleeding on top of risk of bleeding, and you just don't want to get into that. So, but there's this thought about what about patients in AFib?
AFib, right? That's the category we worry the most about for everything, right?
Right. And they're the highest risk of like having more strokes later on. So what do we do with this patient population? So here, therapeutic sub-Q heparin within 48 hours and continued for 14 days was no better than heparin. And there was increased risk of intracranial hemorrhage as well. The risk of death and disability at 6 months was the same. So not really worth it.
Interesting.
Yeah. And then just general supportive care. We all know this, right? You admit that patient to a stroke unit.
Which actually does make a difference.
Yeah.
Just saying.
Yeah.
The stroke unit
there should
outcomes.
Be more of those out there.
There should be. The whole stroke team thing is important.
Yes. And then looking for the sequelae of just having a stroke, right? You can get edema, you can get herniation. So if you have signs and symptoms of that brewing, then you need to get a neurosurgical consult right away. You want to monitor that patient from a cardiac standpoint as well, which we all do.
Because the brain and the heart have a really weird connection.
They're all really important and
the brain
associated
the weird
with
heart
each other.
stuff happens, even though the heart can be fine.
Yes. And you want to make sure that they're in that sort of Goldilocks sweet spot of oxygenation. And if you have fevers, you got to look into that and treat it. Okay. So other things too, right? So unless indicated by treatment, you don't want to like mess with the blood pressure too much, right? This is the idea of this sort of permissive hypertension. Your brain is used to having that elevated pressure. And if you all of a sudden decide to treat a number, not the patient, you get yourself into trouble.
Right. Your brain's smart. It knows it knows what it means.
It auto-regulates to a certain extent pretty well. Right. And then if it's higher, you can consider lowering it by 15% within the first 24 hours if you're worried about this sort of hyper.
Can control.
Yes. Right. Something that is very, easy to titrate. And it's really sort of getting an idea, well, is there a hypertensive emergency contributing to the ischemic stroke here? Right. You want to make sure that if they're going to be stuck in a bed, that you give them some sort of DVT prophylaxis, pneumatic compression stockings.
Right. And that's because the sub-Q heparin thing is a question.
Exactly.
So,
Exactly. You don't want to increase bleeds on top of increased risk of bleeds. And again, screening for dysphagia.
Right.
Okay. Areas of uncertainty. So, there's been this burgeoning idea of mobile stroke units, again, all in the effort of like,
right,
let's go out to the field and see if it's better and figure out the diagnosis earlier.
Scans.
It's cool in theory, but I'm not entirely sure.
They're over $1 million a unit. Like I can think of a lot of ways to spend $1 million.
Right. Yeah. Or you could just get them to us and then we could take care of it
and then also buy regular supplies with that $1 million.
Yeah. Or just a lot of nurses, apparently. That's just
hire a few nurses.
And then the efficacy of mechanical thrombectomy within the first 6 hours of stroke, you got to be sort of really thoughtful of the inclusion patients that you're putting into that category. And then this, again, sort of, I don't know how to manage the blood pressure if it's just a thrombectomy without Acute-Place. Like, what do I do with that? This is tough.
We're learning.
Yes. And then so other guidelines, right? So this really depends on your practice environment.
Well, I'll tell you, in certain countries don't lyse at all. I mean, it is so different.
Right.
Everywhere.
And then some places are really aggressive about thrombectomy.
And some sort of ethnic groups have different responses to therapy. There's higher bleed rates in certain countries because it may be something that's related to your genetics and fascinating.
Yeah. So there's a lot of variation out there, and it really is incumbent on you to sort of learn what it is at your place. What does stand, though, is the IV Acute-Place within 4.5 hours if you meet the appropriate criteria. All right.
So there is an algorithm, by the way, in the article that puts all of this together. If you're an algorithm person, we just didn't want to put it back on a slide because it would be about this big.
Very
and
busy.
Then you wouldn't be able to kind of get your way through it.
Worth going through, though.
It is worth going through. So we'll summarize just the basics here. So start with the NIH stroke scale, get your last known well time. Everybody gets a non-contrast CT as soon as possible. And you may be ordering more studies like CTA, MRA, diffusion-weighted perfusions, et cetera, depending on sort of what your need is at that point in time. If it's less than 4.5 hours, Acute-Place is first line, but you're not going to use it in people with an NIH stroke scale less than 6, anybody with an excessive bleeding risk or brain injury that's irreversible. And again, that's with consultation with the appropriate PEEPs. You're going to give the Acute-Place immediately after negative CT. You're not going to wait for any labs, and you're going to watch that blood pressure, bring it down as needed. And we know that bleeds are higher this way, but the outcomes at least 6 months out are the same. If it's more than 4.5 hours, that's that wake-up study. And this is now NIH stroke scale less than 25. And the lesion has to be specifically sized. And again, that is all stuff that's done at your institution. It's in the papers. We're not going to drag you through this. Acute-Place has been shown to have a treatment benefit. It's actually a little whiffy, but it has been shown that. So it's now accepted. And you may be able to treat even up to 9 hours after the last known well time with specific criteria that was studied in the wake-up study. Mechanical thrombectomy in the less than 6 hour window, it has to be an NIH stroke scale of 6 or greater, very specific imaging criteria, Alteplase first anyway. And then these 2 trials, the Dawn and Diffuse trial, showed some benefit, but no good guide to BP management. Tenecteplase is basically no clear difference with Alteplase. A lot of these are sort of non-inferiority kind of studies. The trials are pretty heterogeneous, but it's now on the plate as something that you could use as an alternative. And anti-thrombotic agents, you're going to delay 24 hours, which actually, frankly, takes it kind of out of what we usually would be doing anyway. But aspirin overall reduces the risk of recurrent stroke and death in the hospital. Dual antiplatelet therapy, again, another 24-hour thing. This is adding aspirin to, like, clopidogrel is usually the thing. It does decrease the subsequent risk of stroke of this, but it's not, and therapeutic anticoagulation isn't better than aspirin alone. So this is, frankly, this is one of those things where I'm only going to take so much brain space with stroke stuff. I'm going to put the platelet stuff out in the chat with the consultant category, not in the remember to snatch it out of my brain category. Admitting to the ICU, neuro ICU preferred for sure. Those teams make a difference. SATs you're going to keep 94%-ish or greater. If they're febrile, which is actually brought up a little bit in the paper, but if they have a fever's not good. Your brain doesn't like to be hot. So treat that fever. And then, of course, go chase it, find the source, treat it if you need to, but get that temperature down. And then blood pressure. Basically, Alteplase really will guide your therapy if you're giving Alteplase in this. Let's get that blood pressure down to the window and target window and keep it there. But if not, if you're not giving Alteplase, you're going to basically let them sit. As long as they're not getting worse, you're going to let them sit. You're not going to treat them for the first 48 to 72 hours. So this is one summary article on stroke that's out there, acute ischemic stroke. Remember, your institution was going to guide your day-to-day therapy. This is what you need to take this particular test. And there's a range of things kind of in between.
Yes.
So.